So, good morning, everyone. In today's CGR, the topic in focus is Chiari syndrome, heterogeneity in clinical presentation, and interventional perspectives, interesting cases. So here we will discuss some interesting cases with varied clinical presentation and role of interventional radiology in their management. To begin with, our senior resident, Dr. Soria, will cover introduction part, and thereafter I will take over and complete rest of presentation. Dr. Soria, please.
Good morning, everyone. Chiari syndrome is a clinical condition resulting from hepatic venous outflow obstruction, which can occur at the level of IVC or at the level of hepatic veins or both. This obstruction leads to congestive changes in liver and liver dysfunction, which has its myriads of clinical signs and symptoms. Also, obstruction of IVC can directly present with its clinical manifestation. So Chiari syndrome is named after George Budd, a British internist, and Hans Chiari, an Australian pathologist. They were the first to describe the syndrome. So first we'll have a look at normal hepatic venous anatomy. This is a schematic diagram showing the right hepatic vein, middle hepatic vein, and left hepatic vein, IVC, and short hepatic veins. Short hepatic veins drain the caudate lobe and are directly enter into the IVC. Here, this is color Doppler image showing the right and middle hepatic vein with wall-to-wall color uptake, the IVC here, the right hepatic vein with its confluence with the IVC, the right, middle, and the left hepatic vein with their ostia and confluence in IVC. Here, this is an axial contrast CT image showing the right hepatic vein, middle hepatic vein, and left hepatic vein opening into IVC. In this image, apart from the hepatic vein, the right and middle, we can see the portal vein, the splenic vein, and superior mesenteric vein. Etiology-wise, Chiari syndrome can be primary Chiari syndrome, which results from endoluminal process like any stenosis, web, or thrombosis in either the hepatic veins or the IVC. It can also be secondary Chiari syndrome, which results from extrinsic compression by a cyst, abscess, or a tumor. According to the site of obstruction, various classification are there, but the classification system given by Patel et al. Is the most widely used. So we call it type 1 when the lesion is in the IVC. We call it type 2 when type 2A when hepatic vein is involved, but involvement is for less than 4 centimeters. It is type 2B when hepatic vein is involved and involvement is for more than 4 centimeters, and type 3 where both hepatic veins and IVC are involved. Again, schematic diagram showing various types of Chiari syndrome. Here in this first image, we can see ostial stenosis of hepatic vein and focal stenosis of IVC with formation of collaterals. In this image, we can see short segment central stenosis of all the hepatic veins. Normally, the hepatic vein should go and drain into IVC here, but this is stenosed region. Here, in this image, there is non-visualization of all 3 hepatic veins with multiple intrahepatic collaterals. So there is difference. There is geographical variation in Chiari syndrome in Eastern and Western countries, which we'll discuss. The prevalence is more common in Eastern countries as compared to Western countries. About gender predilection, it is more or equal to female in Eastern countries, where it is more in female than male in Western countries. Predisposing factors are also different. We'll discuss this in subsequent slides. Anatomical level of obstruction, hepatic vein obstruction is almost equal or more common than IVC in Eastern countries, whereas in Western countries, hepatic vein obstruction is much more common than IVC. Dominant presentation in Eastern countries is subacute and chronic. In Western countries, it's acute presentation. So a study was done on a European cohort about various prothrombotic risk factors for Chiari syndrome. So myeloproliferative disorders were the most common with 39% of the cohort. Then were the inherited thrombophilias. Also, it was seen that single prothrombotic risk factor was found in 84% of the cohort, whereas multiple risk factors were found in 46% of the cohort. Whereas a systematic review and meta-analysis in India showed one prothrombotic condition in only 44% as compared to 84% in the Western population. Multiple prothrombotic conditions were just seen in 7.9%. And of the various prothrombotic conditions, protein C deficiency was the most common, followed by MTHFR mutation, APLA, and JAK2 mutation. It was concluded that Indian patients have lower prevalence of the prothrombotic conditions as compared to the Western literature. So when should we suspect BCS? It should be suspected in abrupt onset of ascites with painful hepatomegaly, massive ascites with only marginally deranged liver function, unexplained chronic liver disease, sinusoidal dilatation in liver biopsy without heart disease, and liver disease with prothrombotic conditions. So clinical presentation can be fulminant, acute, subacute, or chronic. Fulminant, there is onset of symptoms within few days, and these patients present with acute severe liver failure with elevation of liver enzymes. Also, if presentation is with hepatic encephalopathy within 8 weeks of development of jaundice, we call it the fulminant type. This fulminant usually happens with sudden large thrombosis of the hepatic vein or IVC. Acute, it presents in 1 month. It presents with triad of intractable ascites, abdominal pain, and hepatomegaly. In subacute and chronic form, which subacute develops in 1 to 3 months, there is sufficient time for collateral development. So hepatic dysfunction is not that severe. They have variable presentation and may present with ascites and hepatomegaly. Chronic presents in a duration of more than 3 months with CLD, portal hypertension, and esophageal bleeding. Additionally, clinical presentation of chronic Budd-Chiari syndrome can also be seen as congestive myelopathy, paraparesis, paresthesia, bladder bowel involvement, and female patient with recurrent pregnancy loss. 15 to 20% of Budd-Chiari syndrome patients may remain asymptomatic as well. So in a multicentric prospective study of large cohort of patients with Budd-Chiari syndrome at diagnosis, ascites was found in 83%, hepatomegaly in 67%, abdominal pain in 61%, esophageal varices in 58%, and gastrointestinal bleeding in 5%. In 15% of cases, Budd-Chiari syndrome coexisted with portal vein thrombosis simultaneously, and cumulative incidence of HCC with Budd-Chiari syndrome was found to be 4% in a 5-year follow-up. So complications of Budd-Chiari syndrome are portal hypertension with ascites, GI bleed, bacterial peritonitis in presence of ascites, hepatic encephalopathy, hepatorenal syndrome, and hepatocellular carcinoma. Coming to imaging study, ultrasound is the primary modality for evaluation of Budd-Chiari syndrome. So primarily in Budd-Chiari syndrome, we see attenuation of the hepatic veins, hepatic vein thrombosis with multiple intrahepatic collaterals. Liver echo texture may be altered, liver may be enlarged, splenomegaly may be seen, and ascites is usually present. On CT and MRI, we see similar finding. We get CT and MRI done for better delineation of the vascular involvement and also for characterization of the hepatic nodules, the regenerative nodules that develop in Budd-Chiari syndrome. So the main finding in ultrasound Doppler is stenosis, attenuation, or non-visualization of hepatic vein with presence of intrahepatic collaterals. So these are the images of a case of Budd-Chiari syndrome. Here we can see central ostial stenosis of the right hepatic vein and short segment central stenosis of the middle hepatic vein. We can see multiple intrahepatic comma-shaped collaterals, which are better visualized on color Doppler images. In the same patient, there was ascites present in pelvis. So this is the characteristic feature of Budd-Chiari syndrome. Stenosis or non-visualization of veins with development of collaterals. So here, this is CT image. Here we have the normal images for comparison. Here we have image of a patient with Budd-Chiari syndrome. Here we can see normally the right, middle, and left hepatic vein draining into the IVC. Here we can see middle and the left hepatic vein. They are not draining into the IVC, but are drained by a large collateral here. In the same patient, in sagittal image, we can see presence of IVC web. Here we can see the signs of portal hypertension, gastric varices, and the collateral draining the middle and left hepatic vein is also seen here. these are MRI images of patient with Chiari. Here at the level, at the expected level of hepatic veins, confluence with the IVC, we are not able to see the hepatic vein. The right, middle, and left are not seen. Here we see the right hepatic vein with short segment central stenosis with comma-shaped collaterals. There is hypertrophy of caudate lobe because it drains directly into the IVC with slit-like. This hypertrophied caudate lobe compresses upon the IVC with its slit-like appearance. Here again, this is contrast axial image showing right hepatic vein with its short segment central stenosis. And here on post contrast images, we can see collaterals, but these collaterals are not taking up contrast, suggestive of thrombosis of collaterals. Now I would request Anil sir to discuss the management.
Coming to management of Chiari syndrome with focus on interventional perspectives. So general approach to management of Chiari syndrome consists of medical management with anticoagulants forming the cornerstone of management, other being diuretics and beta blockers as required, treatment of underlying condition if any, and radiological interventions in form of recanalization therapy, angioplasty, stenting, and shunt procedures like dips and tips. Surgical management in form of surgical shunts and liver transplantation, and specific management of complications in form of paracentesis, variation, ligation, and infertility management. Of these, radiological interventions and medical management together constitute the dominant therapeutic approaches in management of Chiari patients, with surgical management reserved for only limited number of cases. So various guidelines have been proposed for management of VCS. This is ESL Clinical Practice Guideline published in 2016. And they recommend all patients with BCS should be managed with anticoagulant drugs, and it should be coupled with recanalization therapies in form of angioplasty or stenting of occluded vessels. And if the patient deteriorates or not managed with this angioplasty or stenting, it should go for portal derivative procedures in form of tips and dips. Even if patient fails on tips on dips, then patient should go for liver transplantation as the salvage option. However, patients who present with fulminant course should straightforward go for liver transplantation. These patients should be also followed up for and screened for a development of SCC. So in brief, all patients should, in a stepwise fashion, these patients should be managed with medical treatment coupled with angioplasty, stenting, or thrombolysis as recanalization measures. And if not responding to this recanalization measure, tips should be done. And if not, if tips or dips fails, liver transplant should be considered. Tips can be sometimes also used as a salvage procedure in patients who present with acute severity. Coming to the spectrum of interventional radiological procedures, endovascular recanalization procedures, which can be done in vicious patients. So we do angioplasty and stenting of hepatic vein or IVC, and shunt procedure like tips and dips. So here we create a new pathway between portal and systemic venous system via hepatic parenchyma. So a low resistant pathway is created by passing the resistive liver parenchyma. And post-procedure, all these patients are on anticoagulation treatment, started with heparin and shifted to oral anticoagulants. Here is a this is balloon catheter, which is used for this PTA balloon catheter used for angioplasty. And these are example of uncovered and covered metallic stents. So this is example how we do angioplasty and how it performs. So here in DSA venography image, we can say there is a marked stenosis of upper hepatic IVC with drainage via collaterals. So this stenosis has been crossed with the help of guide wire and catheter, and a smaller balloon has been deployed across it. The balloon dilatation, serial balloon dilatation is done with larger balloons. Balloon is fully deployed, and post angioplasty, we can say there is excellent restoration of antegrade flow from IVC to heart, just with angioplasty. This is another case where by a transjugular approach, RHB has been cannulated. And we can see there is poor venogram shows poor opacification of right hepatic vein with drainage via collaterals. So again, angioplasty, balloon angioplasty of RHB was done. And in view of suboptimal response, stent was placed. And this venogram, we can say there is forward flow from RHB to heart with disappearance of collateral flow. This is how is well expanded stent looks like. So in those cases where we can't perform this angioplasty or stenting, or where we have to do straightforward tapes. So how we do it? So in conventional non-VCS CLD, we do tips, and in such cases, hepatic veins are patent, and tips is this shunt pathway is created from hepatic vein to portal vein. But in cases of dips, usually hepatic veins are occluded. So we have to create this shunt pathway directly from IVC through liver parenchyma to portal vein. So this is modified tips of direct intrahepatic portocaval shunt or systemic shunt. According to clinical presentation, we classified our patients in three groups: those presenting with hepatic dysfunction, CLD, and portal hypertension features only, patients presenting with neurological symptoms predominantly, that is congestive myelopathy, and patients having dominant poor pregnancy outcome as a presentation. So we will discuss these cases in these three groups. Post-intervention follow-up was done with monitoring of LFT, resolution of ascites, any fresh episode of GI bleed, and patency of hepatic vein, IVC, stent or shunt on follow-up Doppler. Additional follow-up criteria in those with poor pregnancy outcome were the history of conception and pregnancy outcome. In those with congestive myelopathy, improvement in neurological symptoms and follow-up MRI. So coming to first group, CLD only group. Case 1, 44-year female, multipara, vague abdominal distension and dyspepsia for 1 year, 1 episode of hematemesis, 1 month prior to SGPGI visit. On imaging, patient was having features of CLD with obstruction of hepatic veins and IVC. Accessory RHB was present, esophageal varices were noted. However, there was no ascites. On upper GI, large esophageal varices were noted, for which multiple sessions of EVL was done. LFT was, however, only marginally deranged. Homocysteine was raised and it was 26.6. So here on this CT image, sagittal reformated contrast CT image, we can see there is short segment total stenosis, obliteration of upper hepatic IVC with visualization of abdominal wall collaterals and marked hypertrophy of caudate lobe. Here in the axial images, again, we can appreciate this collaterals, abdominal wall, perihepatic, paravertebral, and intramural esophageal varices. Here we can appreciate on this coronal reformate dilated patent lower IVC, accessory, patent accessory RHB, enlarged spleen, dilated patent splenic vein. And in these images, that is reformated images, MIP image, and volume rendered images, we can say extensive anterior abdominal wall collaterals. So this patient was taken up for recanalization procedure. And here we see on venography, there is complete total occlusion of upper hepatic IVC with visualization of collaterals. So again, the stenotic segment is gradually navigated with the help of guide wire and catheter. And once it was crossed with guide wire and catheter, catheter was placed across the stenotic segment. Serial balloon dilatation was done. And post angioplasty, we can say there is restoration of antegrade flow from IVC to heart with disappearance of collateral. So this patient is doing well. Case 2, 32-year male patient with abdominal distension and discomfort, intractable ascites not controlled with diuretics, past history of GI bleed. On imaging studies, there was hepatic vein obstruction. All hepatic veins were attenuated, features of CLD with caudate lobe hypertrophy, ascites, upper GI, grade 1 varices, and portal hypertensive gastropathy. On LFT, parameters were mildly deranged, however, protein was on more lower side. On flow cytometry, major PNH clone was detected. So here on this CST images, we can say there is attenuation of all hepatic veins and massive ascites, heterogeneous liver parenchymal enhancement, massive caudate lobe hypertrophy, perigastric collaterals, and prominent patent portal vein. Here again, we can see in the region of hepatic vein confluence, the hepatic vein cannot be visualized. So this patient was taken up in view of non-visualization of hepatic veins. This patient was taken up for DIPS procedure. So here we can see by transjugular route, transcaval puncture was done to liver parenchyma and tract was created. And once we entered the portal vein, the venogram was performed to confirm the position of puncture into portal vein. After confirming it, the catheters were further extended into portal vein and venogram was performed. Here we can see visualization of collaterals and left gastric vein where left retrograde filling. Balloon dilatation of parenchymal tract was performed. After balloon dilatation, a 10 mm diameter stent graft assembly was placed across the parenchymal tract from IVC to portal vein with reconstitution of forward flow and forward or integrate flow from portal vein to IVC by a low resistance pathway. So pre-procedure portosystemic pressure gradient was 27 mmHg and post-procedure which could achieve a pressure gradient of 12 mmHg. The ascites completely resolved, patient is now diuretic free and doing well. This is how this looks like on a radiographic image, the stent graft. This patient also had arterial phase enhancing nodule in right lobe of liver with washout on delayed venous phase. The alpha-fetoprotein was not on much higher range, but over a period of 1 year, there was change from 3 to 7. So SCC was SPC was or consideration and case was taken up for TACE. So here on this DSA angiography image, we can say a tumoral blast in right lobe of liver supplied by RHA branch, small RHA branch. And this is the post-embolization image, which shows disappearance of tumor blast. This is 5-month follow-up CT, multiphagic CT study. On non-contrast, we can appreciate a hyperdense focus in expected location or in treated location. And we see there is no enhancing or washout area. And this hyperdense focus represents the very precise location of that lipidal embolic agent present at the treated site. So there is no residual viable lesion. We can also appreciate the patent DIPS shunt and the difference in the liver parenchyma. See complete disappearance of congestive changes post DIPS. So coming to case 3, 28-year-old male, history of recurrent abdominal pain for 4 years, progressive abdominal distension for 3 months, jaundice for 7 days. On imaging studies, varying stenosis of all hepatic veins with collaterals, features of CLD, ascites, esophageal varices were noted. On upper GI, grade 1 varices were there. LFT was again just marginally deranged, and patient was APLA positive. So here we can say a heterogeneous liver with nodular outline, non-visualization of hepatic veins, and large hepatic and perihepatic collaterals and perisplenic collaterals. And here we can see also this small esophageal varix. This can be also visualized in this oblique reformated sagittal images. And these are hepatic, perihepatic collaterals. At the same time, we can appreciate also this ascites. So patient was taken up for hepatic vein recanalization, endovascular recanalization procedure by a transjugular route. RHB was cannulated. Here we can see the venogram reveals no antegrade flow from RHB to heart or IVC. So there was tight osteal stenosis of RHB, and the drainage in this image, we can say the drainage is via collaterals only. So again, balloon was placed across the stenotic segment in RSV, and balloon dilatation was done, and post-balloon dilatation, a 10 mm diameter stent was placed in RHV with restoration of good antegrade flow from RHV to heart. This patient is also doing well with resolution of ascites. Coming to this next group of patients, those with recurrent pregnancy loss. These patients primarily presented to gastroenterology OPD, but they already had multiple episodes of first trimester pregnancy losses in preceding years. So we considered them in a separate group. So as case 4, 29-year female patient with abdominal distension and pain for 1 month, history of recurrent pregnancy loss in first trimester, imaging studies, total focal occlusion of upper hepatic IBC, hepatic vein thrombosis, CLD ascites in upper GI, endoscopies revealing grade 1 varices. LFT was just marginally altered with higher side of protein, slight marginally higher side of protein levels, Appler profile was positive. So on these axial CT images, we can say this characteristic congestive changes in liver with heterogeneous enhancement. Some of the collaterals and veins are hepatic veins are thrombosed. There is no normal hepatic vein here. Again, we can say there is occlusion of this hepatic IBC with patent lower IBC, pelvic ascites, and dilated pelvic veins. So this patient was also taken for recanalization therapy. And here we can see in the DC image where transfemoral access, we perform DSA and see there is complete occlusion of hepatic IVs with drainage via the paravertebral collaterals. So here, again, balloon was placed across this stenotic segment, balloon dilatation was done, and post-balloon dilatation, we can say there is excellent restoration of antegrade flow from IVC to the heart with disappearance of collaterals. RHV angioplasty was also done in view of partial stenosis of this RHV, and we can say disappearance of collaterals. So this was this pre-procedure image, and this is the post-procedure image with restoration of antegrade flow. Coming to next case, 25-year-old female with abdominal distension, pedal edema for 6 months, history of first trimester, recurrent pregnancy losses. On imaging, varying stenosis of all hepatic veins with chronic thrombotic occlusion of hepatic IVC, features of CLD with ascites. On upper GI, again, there was a small esophageal varices. LFT, again, in this patient, protein was on higher side, and rest of LFT was marginally deranged, and this patient was also Appler positive. So first we attempted transjugular approach for hepatic vein recanalization in this one, but hepatic vein could not be cannulated. So we took this transhepatic access under ultrasound guidance, and then after accessing this right hepatic vein, a venogram was taken. In this venogram, we can say there is central segment of the stenosis or occlusion of this RHB with drainage via collaterals. In this dedicated vena cavogram, we can, via transfemoral route, we can say there is obstruction of hepatic IVC with drainage via collaterals. So in this patient, angioplasty was done and stents were placed both in RHB and IVC with restoration of antegrade flow to heart, both from RHB and IVC. So in this group of patients, poor pregnancy outcome results from a complex interplay of multiple factors, CLD itself being one factor which leads to metabolic and hormonal disturbances. Other is pelvic venous congestion in patients with IVC obstruction, and then post-thrombic status. All these factors can act independently or synergistically, leading to poor pregnancy outcome. So as far as in young reproductive age female BCS is concerned, a given pregnancy status being hypercoagulable condition can itself lead to BCS. And if patients it managed successfully, it can result in a successful pregnancy outcome, or it can be a poor outcome. And the BCS sets in can lead to BCS cycle of poor pregnancy outcome or recurrent pregnancy loss. And similar picture can result also from other causes. So in literature, there are publications focusing on these various factors. So this was a recent editorial in Indian Journal of Gastroenterology regarding role of pelvic congestion in infertile patients with Chiari syndrome. So what they say, infertility caused by pelvic congestion may be expected to be seen more often in patients with BCS caused by obstruction at level of IVC than of hepatic veins. However, studies are needed to see if treatments to relieve pelvic congestion if present will help women with BCS who are infertile or have had prior fetal losses. Apply is again an independent, well-known established factor in pregnancy outcome. As far as CLD is concerned in general, so they have over the years, the maternal outcome in patients with BCS have improved with recanalization therapies. However, live birth rate still remains lower and work needs to be done. And BCS or stable CLD, if BCS is treated, patient is stable, it is not a contraindication of pregnancy. Development of pulmonary hypertension is an important finding that needs further validation in these patients. Coming to as far as outcome in these patients is concerned in our patients. So one patient again post-procedure, both patients post-procedure had first miscarriage again. Post-procedure first miscarriage. Second, and again second patient have repeat miscarriage at 16 weeks recently. The other patient has in post procedure second pregnancy, expecting a 30 weeks gestation, and we hope it comes as a successful outcome. Coming to this third group of patients, that is BCS with congestive myelopathy. These patients presented exclusively with neurological symptoms in neurology OPD. So it is a totally separate class. So 39-year-old female patient, gradually increasing bilateral lower limb weakness for 6 months, backache for 6 months, pedal edema was there. On image, so MRI spine was done, and DL spinal cord edema was noted with paravertebral collaterals. So in such condition, AVF was, or AV malformation was suspected. DSA spinal was done, however, it was found to be negative. So CCT abdomen was done, and that revealed thrombotic occlusion of hepatic veins and IVC with abdominal wall and paravertebral collaterals, features of CLD, along with patent accessory RHB. LFT was just marginally deranged. Homocysteine level was borderline. So this is pre-procedure T2 weighted MRI study. On sagittal images, we can see there is expansion of dorsolumbar cord with T2 hyperintensity and prominent posterior epidural vessels. Here we can see large paravertebral collaterals. So this expansion and T2 hyperintensity of the cord suggestive of congestive changes or edema. On CT, we can see in this axial CCT image, we can say there is obliteration of this LHB, RHB ostium, non-visualization of RHB with heterogeneous liver parenchyma and liver, we can say nodular surface with caudate lobe hypertrophy. There is this accessory RHB, and we can see the thrombotic occlusion, chronic thrombotic occlusion of upper hepatic IVC with dilatation of lower IVC and visualization of this paravertebral collaterals, extensive paravertebral collaterals. We can see the patient also have abdominal wall collaterals. So this patient was taken up for endovascular recanalization therapy. Here we can say the venogram via transfemoral route access was taken, venogram was performed. There is complete occlusion of upper hepatic IVC with visualization of collaterals and no direct integrate flow to the heart. So angioplasty was done, balloon was passed, angioplasty was done, and finally a stent was deployed with restoration of antegrade flow from IVC to heart. This is follow-up imaging, and we compare the pre and post procedure MRI images. We can see in this post procedure MRI of a spine, we can say there is resolution of a spinal cord edema. Patient also significantly improved in clinical terms. When he presented to OPD, he was hardly able to walk even with support. But 1 month post procedure, he was able to walk with help of just a stick. Next case, this was a 48-year-old male patient, daily wage worker from UP working in Mumbai, complaining of gradually increasing bilateral lower limb paresthesia, tingling and numbness for 1 year, no limb weakness, no pedal edema. But these paresthesias were increasing. Patient visited many hospitals, but no improvement, so he came here. So on again, MRI spine was done, and there was edema in lower dorsal and lumbar spinal cord with epidural and paravertebral collaterals. As expected, spinal AVF or AVM was suspected, DSA spinal was done, but it was negative. So CCT abdomen was again done to look for causes of collaterals. So upper hepatic, on CCT, upper hepatic or VC obstruction was seen along with varying stenosis of hepatic veins, paravertebral collaterals, features of CLD, and no, there was no ascites. LFT was just borderline. So we took up this patient for endovascular recanalization management. Here on this MRI, axial MRI images, titubated axial MRI images, we can say expanded cord in lower dorsal region with adjoining this flow signal voids. These are epidural veins, dilated epidural collaterals. On this sagittal titubated MR image, we can appreciate this expanded cord at thoracolumbar junction with T2 hyperintensity and prominent this posterior epidural collaterals. We could retrieve only limited data, CT data of this patient. So here on this axial CT images, we can see here there is caudate lobe hypertrophy with nodular liver surface, suggestive of CLD. And we can see the large paravertebral collaterals with collaterals also extending into psoas muscle and or indenting psoas muscle, we can say. Here on these reformatted images, we can see, this is actually not venous, this is a late arterial phase. And here in the formatted image, we can say there is a sharp interface between this suprahepatic and hepatic IVC with no mixing of the blood, suggestive of an interface. There is definitely an interface. And on delayed venous image, which I retrieved, we can see there is filling of hepatic IVC. So this is a kind of thin layer-like obstruction or membranous obstruction. So on venography, we see again from transfemoral route, venography was performed. We see there is a complete obstruction, a smooth obstruction at the level of upper hepatic IVC. So this was gradually navigated with the guide wire and catheter, and over the wire, balloon was placed across the occluded segment, stenotic segment. Balloon dilatation was done, and post-balloon dilatation, post-angioplasty, we can see there is excellent restoration of this antegrade flow from IVC to heart with disappearance of this collateral flow, to call this collateral channel. As the patient was also having partial stenosis of RHV is done. This angioplasty was done, and we can here see antegrade flow via RHV. So in outcome terms, these both patients did well. First, I described the second patient, we were in follow-up touch with this patient for 6 months post-procedure. Patient clinically improved, paresthesia significantly resolved, and patient was counseled for a repeat MRI. However, patient migrated again to Mumbai for his work and lost follow. So how this congestive myelopathy develops in patients with IVC obstruction? So IVC obstruction leads to paravertebral collaterals. These collaterals are not like a straight low resistance pathway. They are dilated, tortuous with slow flow. So already they are in venous hypertension. So epidural, and then this high pressure in the collaterals or reflux is transmitted back to valveless epidural venous plexus, leading to epidural venous engorgement, leading to venous hypertension in epidural veins. And this impedes the venous drainage of a spinal cord, leading to spinal congestion and edema, and results into features of congestive myelopathy. Other way, this collaterals can directly lead to compression. If they are large enough, they can lead to compression of his spinal cord or exiting nerve roots. The patient sometimes can also have features of radiculopathy. In long term, because of venous hypertension, this arteriovenous gradient is decreased in these patients, and this leads to the poor decreased perfusion of spinal cord, leading to ischemic changes. So this is a normal condition where we can see this is how this normal paravertebral and epidural or radicular veins look like. And this in case of obstruction, where these vessels are quite tortuous. So in literature, there is only limited prospective data on BCS-related congestive myelopathy, and that is only in form of some case reports. So this was a case of venous congestive myelopathy due to chronic IVC obstruction and successfully treated with endovascular stenting. They concluded in cases of venous congestive myelopathy, apart from common typical dural arteriovenous fistula, we should also consider differentials of this venous outflow obstructions. Then there is this another case, myelopathy mimicking symptoms of epidural venous engorgement and syringomyelia due to inferior vena cava stenosis at thoracolumbar junction in patient with BCS, and this was successfully managed with IVC stenting. So they say epidural venous engorgement at thoracolumbar levels may cause symptoms suggestive of myelopathy and can be successfully treated by minimally invasive procedures to eliminate underlying causes. So the take-home message is, Chiari syndrome is heterogeneous in clinical presentation, and apart from those presenting with liver disease spectrum, it should be also considered in patients with unexplained myelopathy and female patients with recurrent pregnancy losses. Endovascular recanalization treatment option is safe and effective in controlling hepatic venous congestion and its consequences, thus halting the progression of disease to some extent. It should be considered in all eligible patients. Thanks.